Hello, everyone. My name is Ann Cleveland, and I am a paralegal at Lyles Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Medicare Telehealth and Telecommunications Technology in Home Health and Hospice. Today's presenters are Jennifer Papapanagiotou and Heidi Kocher in place of Ashley Morgan. Jennifer Papapanagiotou's practice focuses on compliance, regulatory and transactional matters for a wide array of healthcare providers, including home health and hospice agencies. She has extensive experience in analyzing proposed and existing business arrangements, for compliance with federal and state fraud and abuse laws, and drafting a wide variety of legal agreements. Ms. Papapanagiotou is knowledgeable in all aspects of state licensing for home health and hospice providers and in Medicare and Medicaid enrollment, including initial enrollment, changes of ownership, and appeals of revocation actions. Finally, she assists clients with compliance plans, forming new businesses, and addressing Medicare and Medicaid program coverage and reimbursement issues. Heidi Kocher, Esquire, MBA, CHC, is a partner at the law firm of Lyles Parker. She has over 20 years of experience advising and defending healthcare clients on legal and regulatory matters affecting providers of all sizes. She is an expert in all aspects of compliance and privacy programs, including developing and deploying policies, procedures, and training. Her experience includes serving as a chief compliance officer and a chief privacy officer, implementing the various requirements and aspects of corporate integrity agreements, and responding to and defending audits from Medicare, Medicaid, and private insurers up through the ALJ level. She received her JD from Georgetown University Law Center. She is licensed in Texas and Maryland and admitted to the U.S. Court of Federal Claims. She's certified in healthcare compliance. And without further ado, I present your speakers, Heidi and Jennifer.
Thank you so much, Anne. Really appreciate those kind introductions. All right, so today's topic is Medicare telehealth and telecommunications technology as it affects home health and hospice. Couple of things to note. There's a lot of information on this. We've tried to make it as up to date as possible, but it is entirely possible, of course, with this, that things change rapidly, and what is said today may not apply in a month or two. So could we go to the next slide, please? I don't think I have controls. All right. So as I noted, these rules change very, very rapidly. Telehealth is a very dynamic field of healthcare law, and so you're always going to need to confirm what the current rules and regulations are. And the other disclaimer is that, of course, this is for educational purposes only. While Jennifer and I are lawyers, we are not your attorneys, and therefore you should always check with your own counsel when it comes to these matters, particularly, again, since there are so many changes going on in this area. Next slide, please. All right, so we've kind of done a brief agenda here, so we're going to do a little bit of a background on telehealth. We're going to talk some about the COVID-19 waivers that were implemented during the public health emergency specific to home health, hospice, and then a couple of points about the HIPAA waivers as well. And then Medicaid flexibilities, and then some future policy changes. Next slide, please. All right, so diving into telehealth technology itself. Next slide, please. So one of the first things that we need to do is we need to differentiate between telehealth and telemedicine. Telemedicine is remote clinical services, and they're provided real time by licensed healthcare professionals and physicians. Telehealth is all healthcare interactions that are not in person. And the thing to remember about this is that telehealth is broader than telemedicine. And that's because telehealth can include these non-clinical services, things like provider training, administrative meetings, administrative matters, your medical director, for example, continuing education and quality improvement activities are all just some examples of this. So we're kind of talking about telehealth, but remember these distinctions. And one of the points here to note is that definitions are very, very important in this field, and you'll want to make sure you know what the particular definition is of something. Different payers may have different definitions for some of these things. So that's very important. All right, next slide, please. So what is it? Again, as I noted, it is a rapidly changing and developing field. And this, more than some other areas of practice and medicine, really focus or really are impacted by state level laws and regulations. So you need to be checking in and again making sure that your state level regulations, that you're meeting your state level regulations. We've actually tailored this presentation to be more specific for Texas, but if anybody is in a border region and you're going cross-border into New Mexico, Oklahoma, or Louisiana, you might want to make sure that you also understand what is happening in those other states. These laws and regulations do have subtle differences and distinctions, and that can directly impact your ability to provide services and to obtain reimbursement, particularly at the state Medicaid level. Now, when COVID hit and they granted public health emergencies, as part of that, they enacted a number of flexibilities in relation to healthcare because everything kind of went remote, right? And people did not feel comfortable coming into these offices and so on. There has been interest in extending many of these flexibilities. There also has been, to some extent, reluctance to extend some of these flexibilities because of a variety of concerns, including fraud and abuse concerns. So whether or not these flexibilities remain in place after the public health emergency ends is to be determined. There is a lot of discussion at the federal level and at the state level about what may be made permanent after the public health emergency expires. Next slide. So one of the first things to do is to look at the technology and make sure you understand exactly what technology is. And again, we have some distinctions here across different payers. So we're going to here pull out the Medicare ones. Telehealth is interactive communications that includes audio and video equipment, and it permits a two-way real-time interactive communication between the patient and the distant site physician or practitioner. So real-time audio visual, that's things like your conferencing apps and so on. Again, video is very important in this one. Asynchronous store and forward, that's a transmission of patient's medical information from an originating site to a physician or practitioner at a distant site. And then the physician or practitioner at that distant site can review the information without the patient being present. A perfect example of this is the use of radiologists. You take the images and a radiologist comes and looks at the image and then offers an opinion and writes a report, right? We also have an originating site, that's where the patient is, and the distant site, that's where the physician or practitioner is. These are non-simultaneous, which means the practitioner and the physician are not on at the same time. And again, states can and do have very explicit definitions of what technology is permitted. Jennifer, can you take the next slide real quick for me? Jennifer? All right.
Sorry, I was on mute. No, I'm here.
Okay. Just if you could just take this slide for me, please.
I can do it.
Thank you.
So HHS has identified 4 different methods of telehealth interactivity. So there's the live 2-way interaction, which is basically a video visit, simultaneous. Practitioner can see and hear and interact with the patient, and the patient can likewise see the practitioner. Of course, there are sort of the latest and greatest, newest things, mobile health apps and remote patient monitoring products that are becoming more and more prevalent. And then this store and forward technology that Heidi was describing for things like teleradiology. The Texas Medical Board has weighed in and told us that their definition of telemedicine is technology that allows the provider to communicate with and see and hear a patient in real time. Now, this is, of course, acknowledging that there have been some relaxation of these state requirements for what constitutes telemedicine during the public health emergency. And I would just caution everyone that we're going to talk about specific waivers under the Medicare program, because that was the focus of this particular presentation. But it's important to understand that state licensing boards have also issued temporary waivers to allow certain forms of telemedicine that are going to go away when the public health emergency ends, unless the states or the state licensing board takes affirmative action to change their rules. Texas Medicaid has a broader definition of telemedicine and permits different kinds of technology depending on what the service is that's being provided. They permit 2-way video and audio or data transmission in certain scenarios, and store and forward care, as well as some services to be provided by phone or exchanges of facsimiles. But again, there are so many different aspects and ways that you can engage with patients via technology that it sometimes very much depends on the specific scenario or facts you're dealing with in evaluating what the rules are that apply at any given moment in time. We wanted to give a background here because we want you to understand that the rules for what home health and hospice can do are one thing, but you're somewhat reliant on the upstream practitioners who see and refer patients to do their job in a compliant way and to engage in telemedicine if they're using that in a compliant way, because if their service isn't compliant, both with state law and coverage policy for whatever the payer is, then it affects the coverage of your services when you eventually take that patient and care for them. So let's go to the next slide. So there are certainly issues with telemedicine and telehealth in general that are directly tied to the availability of this technology in certain areas of the country. In Texas specifically, we don't have broadband throughout the state. Nationally, the Federal Communications Commission says that 53% of people do not have access to what they call benchmark service, and that's 25 megabit per second. I think that's down, and 3 megabit per second up. So speed of access can be a real issue. It either limits the kinds of technology you can use or affects the quality of that technology. It affects quality of resolution, especially if you're doing things like teleradiology. That's very important. And it also can affect the kinds of security you'll use in various transmissions. Let's go to the next slide. I wanted to share a map of, Heidi, you back?
Yes, I am.
All right, let's let you take back up.
Okay, thanks. Thank you for pinch hitting there for a moment, Jennifer. This map I find very, very interesting. This is from the Federal Communications Commission, and what it does is it looks at the availability of broadband across the nation, and maybe kind of hard to see, but we zeroed in on Texas. And there's a couple of interesting things here. So the different colors indicate the different abilities of broadband in Texas. And what I want you to focus in on is the yellow or perhaps light green areas. those are areas where there is limited access, and it just makes it really hard for patients. And as you can see, there are significant areas in West Texas, and even some areas in East Texas where there is significant limitations on the broadband. So what this means is that practitioners may have some broadband, but the patients don't. And so this is going to limit the ability of patients and providers to utilize telecommunications and telemedicine and telehealth capabilities to deliver services. Obviously, in our big metro areas, we have pretty good coverage with, high-speed internet and so on. But there are many, many areas across the state that do not have this kind of access, which is obviously going to seriously impact how these services are delivered. Next slide, please. So we also wanted to touch basically on what the situation was prior to the public health emergency, because again, as we noted, there is a lot of debate going on right now in the agencies as to how much of this will remain with the flexibilities and how much they are going to go back to the pre-pandemic state of affairs. So prior to the PHE, the service had to be listed on a specific list of Medicare telehealth services. We're not going to go into those in depth, but the link is here. You can look those up. And in addition, it had to be an interactive audio-visual system, which allows real-time interactions between the practitioner and the patient. It had to be furnished by a physician or another authorized provider. And it had to be furnished to an eligible individual, and the individual or the patient had to be in what was called a telehealth originating site. And that was originally not a patient's home. So they had to be in some kind of other setting prior to the pandemic. Next slide.
Heidi, I would just add to that, in addition to it couldn't be the patient's home, there was also the requirement that the patient reside in a rural area.
Yes.
And that's another serious complication in the coverage of Medicare telehealth prior to the pandemic.
Right, especially when you layer it onto the map that we showed you with the limited broadband areas. So yeah, it really made it very, very difficult. You had to do telehealth, but you couldn't do it, and you had the rural problems
I
as
think
well.
really so. the most frequent telehealth services we saw pre-pandemic tended to be rural hospitals seeking consults with specialists.
Yep. Exactly.
And that was really the meat and potatoes of telehealth before the pandemic.
Right. Yep. So again, prior to the pandemic, this here is a listing of the various sites that were permitted to be originating sites. So a physician's office, as Jennifer said, a hospital or a rural health clinic, a federally qualified health center, or some kind of other hospital or hospital-based service, a SNF, a community mental health center, a dialysis facility, a mobile stroke unit, or the home of a patient who was receiving home dialysis pursuant to the end-stage renal disease benefit. Just a patient's home was not an originating site, except under the comprehensive care for joint replacements model, and again, as noted, home dialysis. So that really limited the availability of telehealth and reimbursement for Medicare patients prior to the pandemic. Next slide. There are also some issues with HIPAA. Basically, the same requirements under HIPAA that you have in face-to-face interactions and services apply to telemedicine. As you can imagine, because you're now using technology, security rule issues are of particular importance, and anybody who was engaging in telemedicine really had to make sure they had compliance with all the requirements of the security rule. So under HIPAA, you have some minimum requirements for a telemedicine system, and that is full encryption of any and all data transmission, no storage of video transmission, and secure peer-to-peer networks or connections. And this made it sometimes very difficult. And as Jennifer said, for that reason, we didn't see a whole lot of uptake on telemedicine prior to the pandemic, except with, hospitals and so on, who really had the wherewithal to invest in this kind of security and technological structure. We have some other potential HIPAA issues. The use of unsecured medical devices like telephones, cell phones, and systems, which is email and text message, is an ongoing big issue. You can imagine, it's one thing if the patient chooses to use their cell phone, and I've seen that multiple times where a patient uses their cell phone, sometimes sitting in a car, but it's another thing entirely if you're the practitioner and are charged with complying with these requirements if you're using a cell phone. Other major issues are insufficient training for the staff about technology and HIPAA compliance. That's sort of a perennial complaint. Notice of privacy practices did not contain information about telemedicine when the providers were utilizing telemedicine. So that was a very important and, again, an ongoing issue. There are no business associate agreements between the telemedicine providers and the entities actually providing the system. There's no unique logins or passwords for providers, and there were insufficient audit logs or audit trails. These are all issues that are out there for this, and if you're using any kind of a telehealth system, these are things that you need to be aware of as well. Next slide, please. So again, prior to the pandemic, there were some prohibitions. Skype and FaceTime are not secure, ditto Facebook Messenger. Because they're not secure, they weren't deemed HIPAA compliant. And so previously there was some issues with that. OCR, Office for Civil Rights, which enforces HIPAA, did put into place a waiver regarding use of technology during the pandemic, and they also have said that they were going to do discretionary enforcement. Again, we'll wait to see exactly how much that happens after the pandemic ends. I'm pretty sure that the discretionary enforcement is going to go away, and they will be much more diligent about enforcing issues and violations in relation to technology. So if you're going to engage in this, you need to make sure that your HIPAA policies really address telehealth and telemedicine. You need to train staff. Again, there are a lot of additional considerations with telehealth and telemedicine that your staff may not be aware of, and that you may need to bring your telehealth system vendor into and get their help in achieving compliance. If you're using any kind of telemedicine or telehealth, the housekeeping issues relating to updating software and firewalls is of paramount importance. You cannot let that lapse. Another thing to remember is that even during the PHE, the minimum necessary rule still applies. Now, one thing here is remember that if you have disclosures for treatment purposes, you have a little bit more flexibility, but again, make sure you don't disclose more than you need to. And another major issue is with telemedicine, you have much more likelihood of a breach. So you need to really thoroughly understand how to detect them, how to report them, and make sure you have the structure in place in terms of personnel and so on to help resolve any potential breaches. Among those of us who do HIPAA security work, the mantra is, the saying is that the only difference between provider A and provider B is provider A has had a breach and knows about it, and provider B has had a breach and simply doesn't know about it. So you need to understand how that works. Next slide. Jennifer's going to take it away with some of the waivers that were put into place during COVID-19.
Sure. Thanks, Heidi. Appreciate it. So we really wanted to spend some time focusing on what specific waivers were put in place by the Center for Medicare and Medicaid Services, and also to a lesser extent by the state of Texas and its Medicaid program during the public health emergency, specifically those that apply to the provision of telehealth services. So let's go to the next slide. Waivers in and of themselves are a reflection of the times we find ourselves in. The U.S. president has the statutory authority to declare a major disaster or emergency if they are requested to do so by the governor of a state, or an event is beyond the combined response capabilities of state and local government. So an HHS secretary can also declare a public health emergency, and it's kind of a layered thing. Sometimes one comes before the other. Sometimes the president starts it out, sometimes the HHS secretary starts it out. But the statute says that the HHS secretary can declare a public health emergency for the duration of the emergency or 90 days, and it can be extended. And this is why we've seen over and over again, the public health emergency has to be renewed every 90 days, because it's 90 days or less, generally speaking, and then it may be extended by the order of the agency. Once a public health emergency is declared, it triggers Section 1135 of the Social Security Act, which allows the Secretary of Health and Human Services to waive or modify certain program requirements associated with Medicare, Medicaid, CHIP, and HIPAA. Because all of those programs fall under the jurisdiction of the Department of Health and Human Services. Secretary Azar declared the initial public health emergency on January 31st, 2020. He made it retroactive 4 days, and his declaration has been renewed multiple times, as I'm sure you've seen in the press. The current renewal runs through October 13th. President Biden has promised to give us a 60-day warning if it's not going to be renewed again. We're already past that, and I don't know about you guys, but I haven't heard any news that they're going to end it October 13th. So I am anticipating, although I can't tell you that it's happened already, but I'm anticipating that we're going to get at least one more renewal. I think that makes sense given the uncertainty, what's going to happen over the winter, whether we're going to see a big resurgence or not. But there are so many policy aspects that are affected by the waivers that were put in place during the public health emergency that CMS, sort of seeing that this is eventually going to come to an end sooner rather than later, has already taken action to provide some guidance to providers on what's going to happen with various of the waivers that were put in place once the public health emergency ends. They want people to be prepared so that they can begin taking action now, so that when it does happen, they've got the systems and processes in place and understand what their obligations are. So let's, President Trump, back when this originally happened in April of 2020, also declared a disaster in all states, permitting the states to implement additional waivers and flexibility. So let's go to the next slide. Specific waivers for telehealth were issued by the Department of Health and Human Services, and specifically the Center for Medicare and Medicaid Services under Section 1135. Most were effective on or about March 6th of 2020. And the major ones permitted telehealth and telemedicine to occur across the country and not just in rural areas. As Heidi mentioned, Medicare's general rule for telehealth location, telemedicine service originating sites where they had to be in a rural area. And there's a more detailed definition of that, but that's a gross generalization. It's pretty accurate. And it could not, the originating site did not include a patient's home except in very limited circumstances. The waiver essentially wiped out those limitations and said that practitioners could engage in telehealth and telemedicine anywhere in the United States, and it could extend to the patient's place of residence, not just one of the regulatory originating sites that were on the list that Heidi popped up a few slides ago. This allowed certain waivers related to home health and hospice services so that patients could receive telehealth services in their home that support home health and hospice. Obviously, we don't have a way to bill for telehealth and telemedicine services that are provided directly by a home health or hospice agency through the Medicare program. Understanding there are some things with remote patient monitoring under Medicaid that are possible, but certainly there were services being rendered by practitioners in the community that support getting that patient into home health or into hospice that were fundamentally affected by these waivers. So let's go to the next slide. So the first really important telehealth waiver we got related to home health face-to-face encounters. And the waiver said that practitioners could use two-way audio, video, telecommunications technology for face-to-face encounters when the patient was in their home. And this was a direct result of CMS saying a patient could be anywhere in the country and could be in their home and receive covered telemedicine services. So again, this allowed a practitioner who was going to see a patient and perhaps order home health services to do that via telemedicine. Right now, CMS has given us recent guidance that says when the public health emergency ends, here's what's going to happen. Face-to-face encounter could still be conducted via telehealth, but we're going to revert back to the original pre-public health emergency Medicare requirements that the patient would have to be in a rural area and at an appropriate originating site. So those are that list that Heidi popped up: hospital, skilled nursing facility, a practitioner's office, et cetera. They've also said that the waiver is only going to extend the originating site to the patient's home for 151 days after the end of the public health emergency. So it's not going to come to an abrupt end when the public health THE expires. We are going to get a grace period of 151 days. Congress passed that extension in one of the COVID-related acts. So be aware that if you have practitioners that are seeing patients via telecommunication technology and referring those patients to you for services, that's going to end 151 days after the end of the public health emergency, unless all of the requirements of the pre-public health emergency Medicare telemedicine rules are met. I just want to mention also, I don't have it here on this slide, that there has been some guidance put out by Palmetto, our Medicare administrative contractor for Texas, indicating that if practitioners are using telehealth to do face-to-face visits, it needs to be very clearly documented in the note that they generate for that visit. So it should reflect that they engaged in two-way audio, video, telehealth technology with that patient for purposes of that visit. Just something to keep in mind, so that if and when you're receiving these notes to support the face-to-face encounter, you're covered. If you're not seeing that information documented in what you're receiving, you need to ask why and confirm whether that visit really was face-to-face or if it was done via telehealth. Let's go to the next slide. All right, the second waiver applied more generally to home health agencies providing certain services via telehealth. CMS came out early on and said that home health agencies could provide services to patients using telecommunications technology within a 30-day period of care, as long as it was part of the patient's plan of care and did not replace needed in-person visits as ordered on the plan of care. These telehealth services could include remote patient monitoring, phone calls, and two-way audio-video technology. The kicker, of course, was that you can't bill for a telehealth service. It's not a visit for home health purposes under Medicare. This was really an effort simply to give some flexibility to agencies during the really dire portions of the COVID-19 public health emergency, to allow certain communications to happen and give some assurance to agencies that these were an appropriate way to interact with the patient as a replacement for an in-person visit. Unfortunately, the rules still haven't changed to allow for you to get paid for a telehealth interaction with the patient. And you do have to be very careful about documenting in the physician order and the plan of care should include whether that physician has approved the use of telehealth as a form of interacting with that patient, and it needs to include presumably the methodology and the frequency, just like they would for any other home health service they're ordering. And again, that can extend during the duration of the COVID-19 public health emergency. As of now, this provision has been made permanent beyond the end of the public health emergency. So you'll continue to be able to use telehealth as a way of interacting with patients, but again, they have not, CMS has not proposed a method of paying agencies for these services. Part of that is a reflection of the way the home health benefit is written in the Social Security Act. And unfortunately, it only permits payment for in-person services. Whether that's going to be changed, I don't have a great answer for you right now. I'm not aware at this moment of any legislation or regulatory proposal to change that, although there is some legislation pending that we'll talk about a little bit later that is going to have an effect on some things if it does get finalized. Let's go to the next slide. We've also saw a waiver early on in the public health emergency that dealt with home health aid supervision and on-site nurse visits. CMS, as part of the PHE, waived the requirement that a nurse conduct an on-site visit every 2 weeks, which included supervising nurse evaluation visits with aides if they're to evaluate whether they're providing care consistent with the plan of care. CMS seemed to be very proud of themselves, saying that they extended this waiver with modifications under the 2022 Home Health Payment Final Rule, but really the extension was very minimal. What they've said is that they'll permit one virtual supervisory visit per skilled patient per 60-day episode, and that to replace an in-person visit that's required. But the visit can only be done virtually in rare instances for circumstances outside the home health agency's control, and you must document in the medical record why you can't do it in person. So although CMS seems to be very proud of themselves that they've somehow given agencies this tremendous flexibility, I'm not sure practically that it's all that useful. Let's go to the next slide. So the bottom line is you need to be prepared to resume all in-person visits for nurse supervision and for purposes of meeting the every 2-week visit requirement as soon as the public health emergency ends. Let's talk a little bit about hospice waivers. Like home health, we had a not insignificant, but maybe a less helpful waiver under hospice regarding face-to-face encounters, and a waiver was put in place during the public health emergency, allowing practitioners to use interactive telehealth technology for face-to-face encounters for recertification only for Medicare hospice benefits. Certainly helpful during the COVID public health emergency, and Congress did extend this waiver for 151 days after the end of the public health emergency. So we're grateful for that, and agencies should be preparing to resume and expect their practitioners to resume all in-person visits for recertification once that 151-day period after the public health emergency ends lapses. The good news is that there is proposed legislation that's passed the House that would make the waiver permanent, and actually permanent through the end of 2024. That was passed by the House, and we'll talk a little bit more about that on a later slide. Let's go to the next slide. There was also a waiver similar to what they put in place for home health services that would permit hospices to provide services to Medicare patients receiving routine home care through telecommunications technology, such as remote patient monitoring, phone calls, and two-way interactive audio-video technology, when it is feasible and appropriate to do so. They said in some FAQs that this would include portions of the initial and comprehensive assessments, so long as hospices are mindful of being able to fill the requirements of these assessments and use their judgment as to whether a telehealth platform was appropriate and feasible in each individual case. Like home health, these visits are not, something you can be separately reimbursed for, and only in-person visits are to be recorded on a hospice claim. So you may need to document these telehealth services, but you're not going to bill for these hospice services. They are not visits. This waiver is going to expire at the end of the public health emergency, and hospices are going to have to resume doing all of the things necessary to complete the initial and comprehensive assessment in person. Let's go to the next slide. Heidi mentioned HIPAA and the OCR waiver that was put in place regarding technology for telehealth. So as of March 17th of 2020, and during the duration of the public health emergency, the HHS Office of Civil Rights will exercise enforcement discretion and not impose penalties for use of what they consider non-compliant, non-public facing telehealth technology. These are your FaceTime, Facebook Messenger, Google Hangouts, Zoom, Skype, GoToMeeting, WebEx, etc., all of which are considered not HIPAA compliant. So the waiver applied to the use of telehealth for any reason, regardless of whether the telehealth service was related to diagnosis, care, or treatment for COVID-19. It did recommend that providers notify patients that their technologies were not HIPAA compliant. If that was the case, the patient needed to make an informed decision they would participate, and they need to know it's not compliant technology if they are going to do that. Providers should enable all available privacy and encryption modes and settings that they can in whatever technology they choose to use. And they explicitly permitted that list I just read: FaceTime, Facebook Messenger, Google Hangouts, Zoom, Skype, GoToMeeting, and WebEx. They approved of all of those during the public health emergency. And so they wouldn't impose penalties on providers who don't have a BAA with the telecommunications service provider. So that's important, because nobody's gone out and gotten a BAA with Apple to cover their use of FaceTime. Unfortunately, right now, this waiver is set to expire at the end of the public health emergency. So keep in mind, if you are going to continue using telehealth in your agency in one of the methods that you're permitted to do so after the end of the public health emergency, or one of the extensions that has been granted, you're going to have to be doing it using a compliant platform. And that means going with something that will sign a service that will sign a BAA with you and provide a HIPAA compliant platform for telehealth. Let's go to the next slide. All right, I don't have a whole lot to add for Texas Medicaid with regard to telehealth, but let's go to the next slide.
Jennifer, can I real quickly just mention back on the HIPAA issues? Folks should just be aware that OCR has been making a lot of noises that they are going to really be enforcing the HIPAA requirements, things like the business associate agreements and some of these waivers. They were getting ready to do that. And as Jennifer said, it looks like the PHE is going to be extended past October. But if you haven't been paying attention to your HIPAA compliance in the interim, because there have been so many other things going on, you really should work on coming into compliance for that, because I have a feeling that once the PHE ends, boy, there's going to be a huge uptake in OCR activity.
I agree. We've seen a big increase in HIPAA-related enforcement for things not related to telehealth,
right,
just in general. So I agree with you 100%. Okay, so under Medicaid, specifically the class DBMD, HCS, and TXHML programs, lots of acronyms for you. Those of you who participate know exactly what those are. The Texas Medicaid program, HHSC, said that During the public health emergency, nursing assessments could be provided by synchronous two-way audiovisual technology, so long as it was appropriate for the patient and, quote, driven by patient choice and not provider convenience. Essentially what that meant was the patient needed to consent to the use of telehealth, and it's not something the agency could force on the patient. As of May 1st, 2022, we were provided updates by HHS, and they have said that focused nursing assessments can be done through synchronous two-way audiovisual technology, but comprehensive nursing assessments are going to have to be done in person when the public health emergency ends. So it's a little bit of help going forward after the public health emergency ends. Focused nursing assessments could be done through telehealth, but comprehensive nursing assessments can't. So let's go to the next slide. So what does the future hold? Well, one more, Ian. The 2023 proposed home health PPS rule unfortunately didn't give us a lot more with regard to flexibility for use of telehealth and telemedicine. What CMS is going to do is start collecting data on agencies' use of telecommunications technology, specifically home health agencies. They are proposing to establish some G codes that agencies would report when they do use telehealth services. And they've given us some examples of what those G codes will represent, either synchronous telemedicine by real-time two-way audio-visual interaction, synchronous telemedicine audio only, or the collection of physiologic data digitally stored or transmitted by the patient, basically remote patient monitoring. And what they've proposed for now is that reporting these G codes would be voluntary as of January 1, 2023, but would become mandatory as of July 1, 2023. Again, this is a proposed rule. Feedback is still being collected from stakeholders. I'm not sure when comments are due, to be honest with you. Soon, if they haven't already closed. And while it might be helpful to be collecting this information, I sort of question what they're going to do with it once they have it. Since agencies can't be directly paid for telehealth services and it can't be recorded as an in-person visit, you know, perhaps this will lead in the future to some adjustments or some adjustments of overall reimbursement rates for home health if they see that agencies really are utilizing telehealth in effective ways and that there's some additional costs associated with that. Agencies are, just to be clear, able to include the cost of telehealth services on their cost report as an expense, even though they aren't able to directly bill for these services to Medicare. Let's go to the next slide.
And let me just mention something real quickly on these proposed G codes, team. Folks, there are actually existing G codes out there for non-home health services, so for physician services, for like the remote patient monitoring and so on. So if you're interested in seeing what those codes might be looking like, you might want to just look at the G codes that were established back in, I guess it was 2020, during the PHE for those kinds of things. They're not going to be identical, but I think there'll be a lot of similarities between them. So if anybody's interested, there is something you can kind of look at to kind of get an idea of what might be coming down the pike.
And they generally discuss them in the proposed rule if you really need something to put you to sleep one evening. Plan through the 2023 proposed rule. All right, let's go to the next slide. So the biggest piece of pending legislation that's going to affect telehealth, we hope, and I'm crossing my fingers that this makes it through, is HR 4040, which is now called the Advancing Telehealth Beyond COVID-19 Act. It used to be of 2021, I think, or of 2020. Obviously, we're in 2022 now, so I suspect they're going to change the name of this eventually. But the bill has already been passed by the House, and it was passed with overwhelming support. There were only like 12 no votes on this. It would modify the extension of certain Medicare telehealth flexibilities after the end of the public health emergency. Specifically, it would eliminate all the originating site restrictions. So beneficiaries would be able to receive telehealth services at any site, regardless of the type or the geographic location of where the beneficiary was. So, for example, they can continue to receive services in their home, and that home could be anywhere in the United States. This is a huge change in Medicare coverage policy. You know, as I said, it passed the House with overwhelming support, and it's now sitting at the Senate and has been assigned to the Senate Finance Committee, and that happened right before the summer recess. So as Congress comes back into session, I would anticipate that this will be taken up by the Finance Committee, and I certainly hope to see progress on it during the fall. This pending legislation also includes a provision to allow the hospice physicians and nurse practitioners who do recertifications to continue to do those by telehealth, which is set to end when the public health emergency ends. So that's an important add-on to this piece of legislation as well. So TAHCH has been doing regular updates on this particular bill, as well as, you know, all things PHE, public health emergency, that relate to home health and hospice. So I would strongly recommend that you keep an eye on TAHCH's weekly updates on legislative and regulatory changes. Let's go to the last slide. We have a few minutes for questions. If anybody has any, I don't see any typed in here, but if anybody has a question, we're happy to try to answer those. Otherwise, you've got some contact information here. Feel free to reach out to either me or Heidi by email or phone. I'll admit it's probably easier to get us by email, but you're welcome to call. That's our general number, and our wonderful staff in DC will be happy to get you connected to us. So do we have any questions, Anne?
Not any questions that I can see that relate to the material, mostly just about credits and such. So I feel like that's all concluded. Thank you guys so much. I appreciate it. That was really interesting.
Just to wrap it up, everybody should receive a copy of the slides, and that is sent out after the presentation ends. Give it a few hours to hit your inbox. And Heidi, thanks for joining me, and everybody have a great day.
Thanks so much.
All.